told you before, particularly with ICG, where you actually have a reference as a choroidal vasculature, so you actually see deeper, you actually see the floating lesion, like here. It's between retinal vessel and choroidal vessel. Then you have another very important point, leakage in ICG. You don't have leakage in ICG except for central serous chororetinopathy. So it's quite easy if you use ICG. Then, if you have in OCT intraretinal cyst without retinal, neuroretinal detachment, you have to think about a RAP lesion. Of course, no one of these signs alone give you the possibility to detect, but putting two or more is helping you in doing the diagnosis. When you have a retinal pigment detachment, and you have an interruption of the RP or someone called kissing signs, here you have to consider a RAP. If you have a fluorescein and ICG of the retinal pigment detachment, you see the hot spot in the center of the detachment, you have to think about a RAP lesion. Then you have an indirect sign. If you have a retinal pigment detachment, you treat with anti-VEGF, and it's flattened down completely, you have to think about the RAP lesion. The fellow eye, if you have retinal choroidal anastomosis with or without RIP of retinal pigment epithelium, or in the other eye, reticular pseudodrusen visible, as I told you before, with infrared light, you have to think about RAP lesion. In 85%, 85, 87%, depending on the publication, if you see, there is a correlation between reticular pseudodrusen and RAP lesion. In normal choroidal vascularization, reticular pseudodrusen are present in 20%. So huge difference. PCV. Orange bulge, particularly if you retroilluminate, you actually see better your free orange bulge here. Then can be without or with some hemorrhage. If you have a large hemorrhage, subretinal hemorrhage like this one, or a retinal pigment detachment with hemorrhage and the level of the blood, you have to think about a polypoidal lesion. Now, there are many signs in OCT, but if you have such a things with a very sharp edge and quite dense part inside, you have to think about a polypoidal lesion. Now, do you know why it's oval and not round shape? Also the microaneurysm. Why in OCT it's always oval and not round? Do you know why? Because the retinal thickness is not the right ratio. It's increasing in height to show better the layer. In fact, there are some instruments that you can actually get the real things, and it's very thin and you are not able to differentiate the layers. So if it's round and it's stretched, it's oval. Then you see the retinal pigment epithelium detachment here, but the hot spot is always at the edge, it's not in the center. And if you have an ICG, you can actually see also a fine net with some polyps inside or at the edge of the fine net. Now, when you look at the dynamic of the ICG, you see the pulsatile characteristic of the flow of a polypoidal lesion, you see? And of course, the feeling it's in the mid phase, and there is always a washout if you have a very real polypoidal at the end. The flow is very easy to close, so feeder vessel in this case is not a bad possibility. What about the pseudovitelliform lesion? And I can tell you that pseudovitelliform lesion, most of the time, it's it's misinterpreted like a CMV. And just to give you an example, in the CAT study, there are a series of, in other trials, there are a series of patients that were treated with a pseudovitelliform lesion and was interpreted like a choroidal neovascularization. So, orange coloring in color, infrared, you see an highly reflective material that corresponds to this material here, comparing, with shaggy photoreceptor. Shaggy photoreceptor is not unique for this type of lesion, but you actually see always, and it's difficult to see shaggy photoreceptor in a choroidal neovascularization because it's more acute, there is more movement of fluid, so you cannot expect that the photoreceptor are able to elongate quite a lot. So remember that it could be indirectly a good sign for just saying it's difficult that we have a choroidal neovascularization. Of course, if we use autofluorescence, the material is highly autofluorescent, and if you use a blue autofluorescent, you'll still see the macula pigment, but you don't see if you use a green autofluorescence. Fluorescein, it's important because you actually get the information, but you have to consider there are phases of the fluorescent. You cannot get one single image. So if you look here, you see that there is where we have material is hypofluorescent and then became hyperfluorescent in the mid phase. ICG is always masking, so it's always dark in that area. You will not see an increased fluorescence. What about MacTel? MacTel are usually actually by definition bilateral, temporal side, and if you use a confocal blue reflectance, you see that there is a highly reflective material here. If you use a blue autofluorescence, and this is a possibility to use a blue autofluorescence, we say that why I have to use blue? Well, to see the macula pigment. If the macula pigment does not exist, it means that there is a possibility to have a macula telangiectasia. And in fact, here the measurement with the two wavelength for autofluorescence, and you see that there is no macular pigment. Also, the pigment, the mottling pigment, is always dark. If you have a mottling pigment in AMD, is always bright because it's always hyper-autofluorescent because it's melanolipofuscin. Melanolipofuscin is like lipofuscin, so it's a very highly fluorescence. Here is not. Then when you get the choroidal neovascularization, if you do a fluorescent ICG, you can actually see the deeping vessel here. Then you have the autofluorescent. When you have this hyper autofluorescent correspond to the cyst and do not correspond to the edema that is here. And then you can actually have intraretinal cyst or mottling pigment in both eyes, or one or the other. So these are the possible characteristics, usually bilateral and almost simultaneous, evolution in MacTel. So going back to this case, these 4 cases, are you able to do a differential diagnosis? Of course, if we took the other information, we can actually say that this is a RAP lesion, PCV, pseudovitelliform, and MacTel. And you see that each one has a prominent, test that can actually help to do a diagnosis, but you know, the putting together is better for a real diagnosis. Now, Adam started this morning saying that I'm actually a skier. So here is, when I'm depressed, I'm looking at the movie and I feel much better. Thank you.